have with us. We have planned for a virtual exam session, the table viva session for you, and for you to examine you. We have none other than Professor Yuri Bafna sir and Professor Amita Maheshwari ma'am. So they both the stalwarts don't need any introduction. So I'll request them to please start the session without any delay further. Thank you, ma'am and sir.
And go to the next slide.
Sir.
Okay, now tell me about this instrument. Where do you use it? What is it?
So this is a sir, I'm getting a lot of echo. I'm listening to myself.
I can hear you.
Dr. Suryakant, you joined through two devices. That's why.
Joined through two devices.
Join kiya hua extra.
Is it?
To the mic.
One.
If you are using a headphone, please don't.
How I can exit the screen and
Satyajit can start while Suryakant is settling himself down. Yeah.
Satyajit, you can answer the questions.
Use ultrasonic energy and it is used for sealing the vessel, and it works on the principle of ultrasound. Basically for hemostasis we use it.
how I can minimize the screen?
Only for hemostasis or any other purpose also?
Hemostasis, and we can also use it for basically hemostasis.
Suryakant?
Ma'am, harmonic is used basically for any when you need coagulation. This is an open instrument, open harmonic, used for basically coagulation of during a surgery, any blood vessels, or for dissection, for fine dissection, and we need harmonic. This is where the
No, we can't hear you.
Muted.
Can't hear you.
sir, am I audible now, sir?
Okay.
Sir, we this harmonic is used. This is an open instrument which uses open harmonic, which uses based on the principle of ultrasonography. So there is a piezoelectric substance in the active blade, which is a metallic blade. It vibrates around 10,000, 20,000 kilohertz per second. So thereby it causes crystallization of the cellular and thereby causes coagulation and hemostasis. The advantage of this instrument over our normal bipolar instrument is
Echo.
ma'am, echo, ma'am.
बहुत ज़्यादा.
Lots of echo is there.
Headphones?
I'm using earphones, ma'am.
Okay, so can you come closer to the mic of your device?
No, ma'am, I think I opened two. That is why it is happening.
But now it is better. When you are coming closer, it's better now.
Yeah, use only one device and speak closer.
I cannot exit the screen because I'm sharing.
Okay, no, it's okay now. Please go ahead.
It is okay now, ma'am.
Better.
So that's what I'm telling you. This is a open harmonic instrument. Which used.
Just a minute. What you can do is the two devices which you have logged in through. One of the devices you can just switch off the speaker button. So then it will not echo. One device, if you have the laptop, just switch off the speaker button of your device if you can. The phone or laptop, one device, just switch off this thing. And then it will not echo.
Okay, I'm just trying. Sorry.
Just mute it.
Are you logging through phone and laptop?
No, I didn't. The mail I clicked twice, maybe.
I think in the meantime,
From one of the devices.
I'm sorry, ma'am, for the.
Amit, can
मैम
you
आप
unmute?
मुझे शेयर
Can
कर
you
दीजिए,
just
मैं शेयर कर देता हूँ मैम.
नहीं आप एक से लॉग आउट हो जाओ.
okay?
Ma'am,
Amit,
is it okay?
हाँ अमित तुम मुझे कॉल करो.
यस मैम.
What is happening? I just have to end the meeting, again I'll join.
Sir, in the meantime,
Yes, sir.
yeah.
So now is it okay? Now sir, now I'm audible
Yeah, okay.
and my screen is moving, sir.
Come. Already 10 minutes are passed.
Yeah,
Got
you
just
start
15
answering
minutes.
your question. We'll just look into the screen part. Let me check that.
And
So
you are
start to
using
answer the question.
headphones actually. Your ear.
डॉक्टर सूर्यकांत सर, डोंट नीड हेडफोन. आपकी वॉइस वैसे ही सही आ रही है सर विदाउट हेडफोन के.
Okay.
ये जो ईयर प्लग फोन से ना वो निकाल दो.
यस मैम.
Yes, ma'am.
और अब अपनी स्क्रीन को शेयर कर लीजिए.
Suryakant, you answer the question. Amit is going to share this from the screen. I've sent it to him. I mean, we already wasted very precious time. Yeah, please. You answer
Yes,
the
ma'am.
questions.
So that ma'am, it was a harmonic uh, device which is used for open surgery for that instrument that we saw, that was been shown here, which uses the principle of ultrasonic uh, uh, principle based on the principle of ultrasonography, where there is a piezoelectric substance inside the instrument, and which vibrates to the tune of around 10,000 kilohertz per second. Thereby, that metallic activate that is there at the tip, it causes um, uh, crystallization of the water of the cell, thereby cause the cell lysis, and thereby reducing coagulation of the uh, vessels or the tissue that is there between the active blade and the passive blade. The passive blade is there that contains a Teflon coating, which basically guides to when this active blade is oscillating. It just approaches and it gives a cutting action. So this is what is the instrument.
What is the lateral spread?
Lateral spread of harmonic is lesser than that of advanced bipolar ligosir or normal bipolar. It will be max of 3 to 5 mm. Sir.
So it is much safer than bipolar, and
Yeah,
it
it's okay.
vibrates at the frequency of 50,000
Yes,
kilohertz,
sir. Yes,
not
sir.
10,000 and 20,000. Much higher vibrations.
Sir.
Okay, the next one, similar thing is there. Next slide. Similar thing. Yeah. What is this? This one?
Sir, this instrument is as a thing is a ligation, which is again an open instrument. Here the principle it is used for the same thing for coagulation and cutting. So here basically the current here bipolar current is used for coagulation and cutting of the instrument. This the advantage of this harmonic and ligation are
Here in Covidian instrument,
sir.
the bipolar current is being used. So what is the lateral spread here?
Sir, here it is around 7 mm to maybe 1 centimeter. Around, sir.
So are you talking about lateral spread, or are you
Lateral
talking
spread.
about the size of vessels it can seal? 7
Si-
mm, 1 centimeter, do
size
you
of
think?
vessel.
So
Yes, sir. Yes, ma'am. Size of vessels in this advanced that like I said, they're telling is around 7 mm of tissue it can coagulate at one go. But for harmonic, it is 5 mm.
Yeah, but lateral spread is not 7 mm. Much safer instrument. The
Sir,
advantage of Covidian was a vessel sealing system
yes,
compared
sir.
to routine bipolar. Routine
Yes, sir.
bipolar, you can have lateral spread of 7 mm to 1 centimeter,
Yes, sir.
depending on how much time you are using bipolar. But here in Covidian system, the lateral spread is much less,
Yes, sir.
much safer. It's not 7 mm.
Sir. Sir. Sir.
So it's much safer system compared to routine bipolar system.
Yes,
It is
yes.
a vessel filling system.
Sir.
Okay, next one, next slide.
So maybe now Satyajit can answer.
Yes, ma'am. Yes, ma'am.
Can we go to the next slide?
Next slide, please.
Next slide karo.
Okay. Okay, Satyajit, what is this instrument? Where do you use it?
Retaining abdominal retractor. We use it in open surgeries in exploratory
So-
laparoscopy.
So which is the self-retaining, what are self-retaining abdominal retractors?
We
Can
we
you
have
name a few?
all force self-retaining abdominal.
So
retractor.
is it Balfour?
No, this is not Balfour.
Which one is this one?
What is the name of this instrument?
Thompson's.
Okay.
It looks like Thompson.
Thomson retractor. Thomson's.
Thompson. Yes.
Yeah.
And
What is the advantage? How do you use it? Can you just describe? Have you ever used this instrument?
no, sir. Our institute we use Balfour, but we use Thompson's for only one rod we use when we are doing omentectomy or when we are doing a parotid node dissection. At that time also we can use it, and it basically helps to retract the
Where
abdominal wall.
else will you use it? You said routinely you use Balfour's, but where will you use this retractor?
Ma'am,
Momentum, you said one
Right.
retroperitoneal, but what is
retroperitoneal.
more
upper
than this
abdominal
we
surgeries.
use it?
Upper abdominal, it helps to retract the liver. This
How
retractor
will
and
it one second? How will it retract the liver?
this upper
Is it a liver
No, ma'am.
retractor?
No, ma'am.
undersurface.
No, it is not going to retract the liver. It is the abdominal retractor, not going to
Small
retract the
bowel
liver.
basically help to keep this small bowel at one side, all the small bowel intestines.
How will it help to keep small bowel at one side?
Then the upper
You are
one.
retracting
Upper one.
abdominal walls, right?
Yes, ma'am.
Have you seen it being used?
No, ma'am, not in our
Okay.
institute.
Okay. So maybe
Maybe Suryakanta can answer.
Surekha.
Sir, we use Thomson retractor for upper abdominal surgeries, particularly when we are going for subdiaphragmatic stripping or capsular deposit on the liver or the spleen or the spleen. There to retract the both the the hypercontract part, we put the blades by putting a gauze under the this thing, and we give upward and outer traction so that the rib cage is retracted, and we get a proper more space and view for doing this diaphragmatic stripping.
It is a table mounted retractor. You know, these are table mounted retractors.
Yes,
So
sir. Yes,
assistant
sir.
doesn't have to retract.
Yes, sir.
An advantage of this kind of retractor is that it gives you a good retraction in all directions, and
Sure.
assistant is free for doing other work. So
Sir.
this is called Thomson's retractor. Can you show the next slide so that you will know what is the use? Next one. So this is Thomson's retractor being used. What is the procedure going on here?
It is high pay going on, sir.
High tech.
Yeah, so it is very
Which
useful.
method are we using here? For
Open
high
method, ma'am.
And what are other methods?
There are closed and semi-closed method also.
So it is very useful for procedure like HIPEC for any tumor on the diaphragm, okay, and tumor on the liver. So it gives a very good retractor for it gives a very good exposure of upper abdomen, especially. So next one more retractor is the next one. Show the next retractor. Next slide. Yeah, what is this retractor called? And what is the difference between the previous retractor and this retractor? This is also table mounted. Table
So
mounted
this is
retractor.
Buchwalter retractor.
Buchwalter retractor.
Sir.
Yeah, correct. You are right.
Buchwalter's retractor.
Yeah, Buchwalter. What is the difference between Buchwalter and Thomson's retractor? Which is better?
Buchwalter's
Gynec?
better. because it helps in retraction from all the sides, and it is
Both the
reduced your
retractors,
mobility.
both can retract all the sides.
Yes, sir.
The shape is actually, here you are using a
Circular.
ring shaped this thing, no? You
Sir.
can see it's central ring.
Yes, sir.
The Thomson's retractor, you have rails, two rails you have,
Yes, sir.
upon which you have the various retractors placed.
Yes, sir.
And the type of retractors are different in both Thomson's as well as Bookwalter.
Yes, sir.
Basically, the use is similar.
Yes, sir.
Yes, sir.
Okay, next one. Okay, what is this retractor?
Sir, this is a cryo gun with a cryo tip and the connecting hoods with the nitrous oxide cylinder with the pressure gauge. The whole system of cryotherapy.
Nitrogen, is it? Nitrogen or nitrous oxide?
Nitrous oxide it was, sir.
Okay. Any other gas can you use?
Carbon dioxide can be used, sir.
Which one do you use?
We use nitrous, sir.
Nitrogen oxide.
Yes, sir.
Okay. So what is it used for? What is the procedure like?
Sir, this is a ablative method of treating pre-invasive lesions of cervix.
So how will you select patient? When will you use, when will you not use this method?
Yes, ma'am. So particularly when I am using cryotherapy for pre-invasive lesions, if it is a CIN2 plus lesion and I have ruled out invasion and the lesion contains less than 75% of the os, and the tip that I use, it should totally cover the lesion that is there, or max 2 millimeter around the cryo tip, and the transformation zone should be type 1. And there should be no patient is not pregnant. There should be no active infection PID present in the patient, and it should not be used within 3 months of postpartum. And these are the areas. These are the indications where I take cryo.
Okay. How do you use it? Basically, it is used for when colposcopy is satisfactory and entire lesion is visible.
Yes, sir.
So
Yes,
what is the procedure exactly? What is it called? Cryotherapy. What is the technique? Just be fast.
We call freeze throw freeze, sir.
Throw, freeze technique.
Yes, sir. 3 minute, 5 minute, and 3 minute.
5 minute. Yeah. Yeah. Basically, more than time, you have to wait for the ice ball to form.
Ice crystal.
And it has to spread laterally. How much does it have to spread laterally?
5 mm it should spread, sir.
5 mm to 7 mm it has to spread. Till then you go on freezing it.
Sir.
Okay. Then you thaw it for 1 minute to 2 minutes. Then again you freeze it. And should cover the entire lesion. That is the principle of cryotherapy. Is it better than leads?
No, sir. No, sir. No way.
What is the success rate with cryotherapy for management of CIN2 and 3?
CIN2 success rate is around, sir, 80-85% they tell. But if you look at the recurrence, sir, for CIN3 it is around 30 to 40%, and for CIN2 it is around 20%. 10 to 20%, and that is 20 to 30%, sir, for CIN3.
It's too high. Are you using it? Cryotherapy? Are you using?
Sir, yes, sir, we are using.
Any other ablative method you know?
Yes, ma'am. Thermal ablation is there, ma'am. Carbon dioxide laser ablation is there.
How these two are different in basic principle of
basic
effect?
principle for thermal ablation, ma'am. Here we are crystallizing. This is cooling the temperature, making the tissue, the temperature, core tissue temperature going to minus 85, minus 60 to minus 85 degrees Celsius. Thereby, it crystallizes the intracellular water and it kills the cell. But in thermal ablation, I am giving heat. I am hitting it to the temperature of 40 to 55 degrees Celsius, where.
So how much is the temperature you said in thermal coagulation?
55 degrees Celsius.
Are you sure? Satyajit?
50 to 60 degrees centigrade.
How much did you say temperature?
Sir, 55 degree
30,
Celsius. Yeah? 55 degree it was, sir. 55, sir.
No. not 30 degree. What is the SEMS cold coagulation called? What is the temperature? Is cold coagulation, but is it really cold?
No, sir, it is not cold, but usually in a cutlery when you are using it is above 100. The cutlery, the temperature that is generated, but here it is less than 100. That is why it is called as cold coagulation.
You can see the chat box for the answer.
Achha, someone has typed the answer. They are helping.
I think so.
Okay.
Okay, I think already 30 minutes have passed. I think next go to the next slide.
Yeah. So correct answer is 100 degrees. Some people have already tapped there. Yeah.
Okay, tell me quickly. We have to be fast. What are these instruments and where do you use it?
Sir, this is a linear stapler, sir. Okay.
Yeah, linear stapler. And other one is?
Other one is same. It is a linear stapler, but it is a minimal endoscopic stapler, sir.
No, not endoscopic. Yeah, endoscopic. Right, you're right. Both are linear. One is endoscopic. One is for open surgeries.
Sir.
Where do you use it in open surgery in Gynec oncology? Linear staplers.
Small bowel resection and anastomosis, and also when we do hemicolectomy for to anastomosis, ileum to ileocolal anastomosis. It helps. It basically helps in resection and side to side anastomosis.
Yeah, basically it is used for side to side anastomosis. Whether you are doing small bowel anastomosis, it is side to side with linear staplers. Or you can do iliotransverse anastomosis also. Even that is also side to side.
Yes, sir.
Linear staplers are basically for side to side anastomosis, whether you use it open or whether you use it endoscopically.
Sure.
Yes.
Okay. Next one. Yeah, what is this one?
The circular stapler, sir.
Circular stapler. It's for used for what?
End-to-end anastomosis.
End-to-end
Of
anastomosis.
what? Which structure? End-to-end anastomosis for?
Particularly, we use for rectosigmoid section or low.
No, particularly means can you use it for end-to-end anastomosis of small bowel also?
It is written in book, ma'am. They can use, but mostly I have seen only used for lower rectal, the rectosigmoid resection anastomosis.
How do you ensure that your anastomosis is
Hello, ma'am. You are not audible, ma'am.
Hello. Hello. No, so my question is, how do you ensure that anastomosis is good?
After the anastomosis, we do a bowel check. We fill the abdomen with warm saline, and then we press the bowel from proximal to distal, and whether there is any leak or not, we can see.
What other things you can do? One, you said
and also
that
we
leak
can
test you do from above only, yeah, or from below.
From above we do, and from below we do a septo syringe. We can push the solution, and whether there is any leakage, we can ensure.
No, we don't put solution. I don't know if you put solution. Okay.
Betadine.
Getting answer on the chat box. What else?
Can I answer? Can I answer, sir?
Yeah, you can answer. What else you look for?
Sir, one thing you can do intrap ICG you can give, and with infrared imaging system you can see.
What is more important?
After I detach the donut, I should see the completeness of the donut. Yes, sir.
Quickly, what are the indications for covering stoma after anastomosis?
Covering stoma, ma'am, if at the anastomosis if there is tension, the vascularity is compromised. If it is done if it is below the peritoneal deflection, like low anal anastomosis or in rectoanal anastomosis or ileocolic anastomosis, which is colorectal anastomosis, which is below the deflection. And if I am not happy with my closure, if the donut is incomplete, or if it is done in an emergency procedure following perforation, then I am doing anastomosis. There I should go for a or if the patient has used got chemotherapy, like particularly bevacizumab and on in the NSC setting, and I am doing it in the interval series setting, then I should use and I should put a protective stoma.
Yeah, the most, I think, apart from this, the most important thing is that a patient is having hypoproteinemia and extensive PCI, extensive disease. You have done extensive resection, PCI is very high, and patient is hypoproteinemic, malnourished, even then, even if you have done a good anastomosis, I think better to do a stoma, prophylactic stoma, more
Sir.
important.
Sir.
Okay, next one. Next slide. Yeah, what are these things now compared to you just now you showed cryotherapy. What is this used for?
Sir, these are loop electrodes used for loop
Elite.
electro-excision procedure or LEDs or lead procedure, sir.
So what is the difference between the cryotherapy and LEDs?
So they are ablative where we don't get tissue post procedure for histopathological analysis, but here we have tissues for histopathological evaluation. Second thing, the depth that we cover through we cover through ablative, it is more in case of excisional procedures.
Yeah, can you use it for type 2 and type 3 transformation zone? The
Type
lesion
2
is going inside the endocervix.
type 2 transformation zone we can use, sir. Type 3 I think it is a little difficult, but can be done. Multiple pass you have to go. I don't know, sir.
Satyajit, how about you? Would you like to use when the lesion is extending into the endocervix?
The complete transformation zone should be visualized. Basically, we can do it for type 1, but type 2 also can be
So
done
for
in
leap, you are
multiple
saying
layers.
you will not use for type 2? Complete transformation zone should
Type
be
2, we
seen?
can do it in multiple sections we can do. And basically for type 1, we are doing.
No, so what do we do for type 2 then? If you say both ablative and excisional only for type 1, so if there's type 2
Type 2
transformation
also,
zone, then what will you do?
type 2 also it can be done now. Type 2.
Procedure which you know of?
For other excisional procedure, ma'am, you are asking?
Elite
Yeah.
is
So what is the difference between LEDs and LEAP?
Here, okay. Leap is ma'am only loop excisional, and this is large loop excision of the transformation zone. LEDs.
So I think these are just American and British this thing. It's not that in LEAP loop you can't use large loop.
Yes, ma'am. Yes, ma'am.
Okay.
Yes, ma'am.
So Dr. Seema asked any other procedure you can do if it is type 3.
We can go for conization, ma'am.
Okay.
CKS. Yes.
Okay. Next one. Next slide, please. What are these instruments, sir? This one. And can you show the next one also? Next one.
Should we move to the next drugs? Because
Yeah, I think very better.
This is Satinsky hemostatic clamp, sir.
Vascular clamp. Next one. You don't have time. Next one.
This is Bulldog's hemostatic clamp.
Bulldog. What is it called? Bulldog clamps.
Bulldog's hemostatic clamp.
What is it called?
Clip. Bulldog hemostatic
hemostatic clamp.
DBACI. Depending on the type of the jaws, you have two types of vascular clamps. One is DBACI. DBACI clamp can have various shapes and size.
Yes, sir.
Apart from the DBACI clamps, DBACI clamps are more wider. The clamps are much wider. And there's one more type of clamp is there. What is it called? Any idea?
That is also DBACI hemostatic forceps, sir. It will be right angle type, just a long transverse limb. That is DBACI's hemostatic.
See, this one more is that Castaneda clamps are there. Castaneda is much more thinner, 1.4 mm thin, basically used for pediatric use. And these DBACI clamps are much wider clamps. We have various shapes and sizes, small clamps to bigger clamps you have. So these are the two types of vascular clamps are available.
Sir.
Castaneda and DBACI. Next one. This one is very commonly used. What is it? Mixture. Where do you use it? You can use it at various places, but where do we use in oncology?
Debriefing of ureter in radical hysterectomy, basically, and for creation of pararectal and paravesical spaces. Also, we can use it. Basically, for dissection, we use it.
Use it for creating paralateral space, is it?
And deroofing of ureter, that is the most common use.
Deroofing of the ureter mixture.
Also, it can be used for one any tubular structure to put a loop and for ligating the vessels.
Right. Okay. Next one. Next slide. What is this clamp? Very commonly used nowadays. We don't use it much. I don't use it much. What is it?
This is Hennis hemostatic.
Hennis clamp.
Hennis
MD level question. MD OBG, MS OBG level question. Hennis clamp.
Sir.
Are you using it?
No.
Are you using it, Suryakanta?
No, sir. No.
So,
sir.
which clamp you all use then? You use Roberts or Cockers?
Not Cockers, ma'am. We use that normal clamp, which don't have this. That here you can see that horizontal tooths
So
are there. That smoother one we use. So the serration will be there, but not that tooths.
Okay. So nowadays, I think different surgeons use different kind of clamps. Coccus clamp can be used, or this Hennis clamp can be used. I don't use Hennis clamp also. I don't use Coccus clamp also. I use ordinary artery forceps.
Yes.
Long artery forceps.
Yes.
Okay. Next one. Yeah. Coming to the drugs now. Carboplatinum. Can you tell me about the carboplatinum and difference between carboplatinum and cisplatinum?
So these are platinum compounds who are basically alkylating agents of the cell cycle, non-specific. Both causes intercalation of DNA. The platinum goes and adapt to the DNA, thereby causing DNA breaks and cell death. The difference between cisplatinum, platinum, and carboplatinum is cisplatinum side effect profile wise, cisplatinum has more autotoxic, neurotoxic, and nephrotoxicity. But carboplatinum has less of nephro, neuro, and auto, but more of hematological toxicities.
So, which drug do you do HIPEC?
No, ma'am. We do NIPEC.
You do?
NIPEC, madam.
Okay. So, which drug do you use in NIPEC?
We do cisplatin. We use cisplatin.
So, what precautions do you take while using cisplatin?
Because cisplatinum is because of the nephrotoxicity, we have to give pre-hydration of around 1 to 2 liter of normal saline, and in that we give one mannitol as a diuretic. Then we give potassium chloride and magnesium sulfate, 1 ampoule of KCl.
Even while using in NIPEC, you give mannitol.
Ma'am, our protocol as per as Madam follows, ma'am, we give. Then we give KCl and Maxol to each pint, 1 ampoule of KCl and 2 ampules of magnesium sulfate. And recently we have started using sodium thiosulfate also for our NIPEC patients.
So which is better for NIPEC, cisplatinum or carboplatinum?
Cisplatin.
Both for NIPEC as well as HIPEC, which is
cisplatin is what is used in whatever evidence we have is mostly with cisplatin.
Any study has used carboplatin? Any literature in intraperitoneal route?
Ma'am, intraperitoneal chemotherapy, carboplatin is used, ma'am.
No, HIPEC I'm asking. So any study on HIPEC has used carboplatin? Are you aware?
No, ma'am. Sorry.
Okay. Have you? Do you know that MSK HIPEC in recurrent ovarian cancer trial? Phase 2 study. Okay. Fine.
I don't know.
Okay. Please
MSK trial has used carboplatinum for recurrent ovarian cancer. Okay. MSKCC has used carboplatinum instead of cisplatinum.
Okay, sir.
And what is the dose used? Any idea? You don't know. I don't think you'll know. What was the dose used? Carboplatinum intraperitoneally by MSKCC. You know all this more than us.
I think he doesn't know the trial, so dose he won't know. But what dose do you use of cisplatin in IPEC or HIPEC?
For in our study, we are using 75 ma'am.
75
But
to
for
100
HIPEC, as per the Vendrell protocol, it is 100.
So don't
Also,
say flat dose; it is per meter square.
yes,
It's
ma'am.
not
meter.
75
Yes,
flat
ma'am.
dose.
Sorry, ma'am. Yes, ma'am. It is 75
Platinum,
milligram.
various authors have used various doses, 75 mg to 100 mg.
Yes, sir.
Above platinum, you use a dose of 800 mg per meter square. That's so high doses has been used by MSKCC. We don't use that high because we keep it and we don't remove it.
Yeah, with 75, you said you have recently started using nephroprotection, but before, were there any nephrotoxicity in your study?
Ma'am, no one has like a renal failure thing. One patient we have a little creatinine was raised. After that, madam.
Okay, fine. Anywhere in Gynec, most places carbo and cis have shown to be equally efficacious, but any study has shown carboplatin to be inferior than cisplatin?
Yes, ma'am. In CA carcinoma cervix, when we are giving in recurrent CA cervix, when we are giving cisplatin paclitaxel versus carboplatin paclitaxel, if the patient for the patient cisplatin is not used prior, and we are giving cisplatin with paclitaxel, it gives better survival as compared to carbo and paclitaxel.
I'm not aware of this study where cis and carbo. I mean, we use carbo only in cervix.
Yeah.
Any other ovarian cancer, you know?
BEP regimen, cisplatin is
Germ
used.
cell tumor, germ cell tumor.
Germ cell tumors.
Yes, BEP. You know, there is
Yes,
a
yes,
study
ma'am.
which showed in testicular tumor, which showed
Yes, ma'am.
carboplatin to be inferior.
Yes, ma'am.
Yeah, BEP regimen, we always use cisplatinum. We don't use
Cisplatin, yes.
carboplatinum. We don't use. Okay. Cervical cancer, we can use both paclitaxel and carboplatinum.
Yes,
Very
yes.
easily.
In
It's
fact,
equivalent to
first line is carboplatin
Pacli,
only,
yes,
but
ma'am.
most patient must have received cisplatin in concurrent setting.
Yes, ma'am. Correct, ma'am.
Okay, next, let's.
Okay, this is all covered. Next one. Okay, paclitaxel. What is the mechanism of action of this drug as compared
So
to
this,
cisplatinum? Cisplatinum causes inter and intrastrand formation in the DNA.
yes, sir. Bricks.
Because paclitaxel,
It is a cell cycle specific, sir. Basically, it acts on the M phase of the cell cycle, where the taxol goes and binds to the tubulin polymers. It causes polymerization, but it is so aberrant and it stabilizes, so they don't depolymerize, and thereby no aster formation. The cell dies, sir.
yeah, it binds the macrotubules. So cell cannot divide.
Sir.
Cell cannot separate into two cells because it binds the microtubules. What is the mechanism of action of paclitaxel? What is the toxicity and what are the precautions you take?
Paclitaxel, mostly it is because of the chemophore C, the vehicle that is used for the paclitaxel, the suspension. It causes allergic reactions because of this vehicle that chemophore content.
Yeah, it can cause
And
anaphylactic reactions.
reactions, and which usually it's in. And apart from that, it has alopecia as a side effect, neuropathy as a side effect,
Neuropathy.
and
Dermatology toxicity.
even myelotoxicity is also there. Sir.
What is the main toxicity apart from this thing? What is the important toxicity?
Neuropathy.
Neuropathy, peripheral neuropathy.
Yes, sir.
Peripheral.
Almost
Peripheral
all the
neuropathy.
patients would get peripheral neuropathy.
Sir.
Globe and stocking pattern.
Globe stocking
Globes
type
and
of
stocking
neuropathy.
pattern of
Yeah, glow and stalking, tingling and numbness. Typically, tingling and numbness.
neuropathy.
Hand and feet, you feel tingling and numbness. Glow stockings, peripheral neuropathy. Can you prevent it?
Prevention.
Can you prevent
You can use
peripheral
NAP
neuropathy?
paclitaxel.
No, sir. You can prevent it by giving other drugs which have
NAP
less,
paclitaxel causes
like
less.
NAP paclitaxel or albumin-bound paclitaxel, Gynoxol. There are a lot of other formulations.
Yeah, NAP paclitaxel also cause peripheral
But the
neuropathy, but
severity is
it
less.
can be reversible. NAP paclitaxel and
Yes, sir.
nano-paclitaxel, various formulations are available. They
Yes,
cause
sir.
less peripheral neuropathy compared
Yes,
to paclitaxel and
Sir.
less anaphylactic reaction. So you
Yes,
don't
sir.
have to use antihistamine and proton pump inhibitor while using NAP paclitaxel. Okay.
Yes, sir.
Next one. Methotrexate. Tell me now about methotrexate. How does it
Sir,
act?
Dihydrofolate reductase inhibitor, sir.
Hmm?
And
They want hydrofolate inhibitor. So anti-metabolite.
it is an anti-metabolite which acts on the phase, which
yes,
when it basically inhibits the dihydrofolate reductase enzyme. So thereby the folate is not converted into active folate, which is the one carbon atom donor. So thereby it DNA synthesis is inhibited and cellular dies, sir.
Okay, what are the side effects?
Side
Is it
effect,
alopecia?
yes, sir.
What is alopecia?
Mostly,
hepatotoxic.
Satyajit, does it cause alopecia?
Sir, I told hepatitis. I mean, a transient elevation in the liver enzymes it causes.
No, I'm asking you, does it cause alopecia?
Alopecia.
Paclitaxel, definitely it will cause alopecia. All the patients.
Paclitaxel causes. Methotrexate.
Cisplatinum, does it cause alopecia? Cisplatinum and carboplatin?
No, sir.
No.
To very less degree,
It
but
causes alopecia, minimum alopecia, not much.
minimum,
Some hair
minimum.
loss is there, not much. Methotrexate also does not cause alopecia. Minimum alopecia is there with all the drugs, but usually does not cause alopecia. What are the main side effects of methotrexate?
sir,
Transient
main
elevation.
is myelosuppression.
Myelosuppression.
Then hepatitis, sir.
Hepatotoxicity and
Also nephrotoxic, sir.
most important, what? Mouth,
Ne-
you can get GI and mouth, you get ulcerations. You
Yes,
get.
sir. Yes.
That is very
Mucositis.
common. First
Mucositis.
cycle and second cycle, you can get ulcerations in the mouth, oral mucositis.
Yes, sir.
Very common with methotrexate. Okay, next one, bleomycin. What is it? Bleomycin. It is an
Bleomycin is it is again one anti-tumor antibiotic
antibiotic, anti-tumor antibiotic.
which acts on the G2 phase of the cell cycle, and um, it is used for our germ cell tumor in the BEP regimen, which is given day 1 and day 8 of the pre-cycle regimen at a dose of 30 milligram flat, sir. And it has a side effect of pulmonary fibrosis and skin toxicity.
Skin? What toxicity? Skin toxicity?
Skin, it causes rashes and discoloration and
Skin pigmentation.
Pigmentation, yes, sir.
And interstitial pneumonitis, very
Yes, sir.
common with bleomycin. What is the dose? Upper limit of the dose?
Upper limit is 300, sir.
300 only.
Yes, sir.
Total cumulative dose.
We should not go beyond 300.
Not cause interstitial pneumonitis. Very high chances of having interstitial pneumonitis. Beyond what dose?
Beyond 300, because they only give
400 to 500. Beyond 500, 20% would get interstitial pneumonitis. Beyond 500, you can get at any dose, but beyond
Yes,
500 mg, about 20% would get interstitial pneumonitis, which is very severe. Causes a lot of distress, dyspnea, cough.
That's why before giving BEP, a PFT and diffusion capacity of the carbon monoxide DLCO has to be done. So, and the vital capacity in the PFT has to be seen before starting BEP.
I think we have specimens also. Should we quickly
I think
cover one or two?
Already 8:20 now. Next one. Go to specimens. I think better go to specimens. Not have time. Next one. Next one. I think, do we have the time for this, Amita? I don't think we have time.
Okay, so then we will finish with. Okay, let's quickly ask one or two on targeted therapy.
Okay, targeted therapy. I think one is here. Bevacizumab. Next one. Can you show the next one also, so that we can save time? Keytruda, pembrolizumab. Can you tell me about bevacizumab and pembrolizumab?
Sir, bevacizumab is a monoclonal antibody which is against the vascular endothelial growth factor receptor A, against VEGF-A inhibitor, which is responsible for angiogenesis. So by giving bevacizumab, it inhibits the VEGF molecule and thereby
What are the approved
diminishes.
indications for use of bevacizumab? US FDA approved indications in gynec oncology.
Use of
Cervix,
Hmm?
ovary.
C ovary. What's C ovary?
Sir,
Recurrent,
Specific.
recurrent CS cervix, it was first used. After that, it is used in as a maintenance therapy in carcinoma ovary. Basically when there is a very bad disease like ascites or incomplete
bevacizumab is used
where we are unable to achieve R0 in that condition.
Does it improve overall survival?
No,
for ovary, no
no,
overall survival benefits, sir.
Then why is it approved then? Why is it approved
PFS.
by FDA?
It has got
PFS.
progression-free survival advantage, sir, of around
What?
3 to 4 months.
No. Why is it approved? If overall survival is not improved, why is it approved?
It is approved based on the PFS benefits, sir.
And improves the quality of life of the patient.
Basically, PFS is improved.
Huh.
Progression-free survival is improved, and it is good for patients who have large effusions, ascites,
Yes, sir.
pleural effusion, suboptimal debulking. So
Sir.
because of this, it is approved, not because it improves overall survival.
Yes, sir.
It is approved for advanced epithelial ovarian cancer. When
Both
you
in
say
both
ovarian
in
cancer, you must be specific. You cannot say ovarian cancer.
both in
Advanced
advanced,
ovarian cancer.
upfront and recurrent settings, sir. In upfront setting, in all advanced stage 3, 4, in stage 2 onwards as a maintenance, but it has to be used during the chemotherapy. Then we can use it in maintenance setting as per the
Is it
icon
approved
7,
for stage 1
icon
and stage 2
7 and
also?
GOG.
Stage 1 and stage 2 epithelial ovarian cancer? Is it approved?
So stage 3 to stage 4 is the approval, sir. But in the
Basically for
trial, they
advanced
have
ovarian
taken
cancer.
stage 2 also. And the trial for that is icon 7 and GOG 218 in upfront setting maintenance, sir. We can use along with olaparib as from the Paula's trial, sir. In the recurrent setting also.
Okay, so Paula, you mentioned what is the biggest limitation of Paula's trial?
Ma'am, biggest limitation of Paula has two arms. One was bevacizumab with olaparib, and the second one was bevacizumab plus placebo.
Right.
So they don't have a third arm which gave only olaparib. So
Right.
whether the benefit that we got is only because of olaparib or it is a additive from ola and bev or only bev, it is difficult to conclude from the trial.
Yeah, that is not known. Whether olaparib alone is equivalent to combination of olaparib and bevacizumab is not known. But I think
But from
bevacizumab
we
is
compared the solo trial, sir, where only olaparib is used, and we compare the hazard ratio of both, it is almost equal.
You think these two are comparable?
No,
in
cross
terms of
trial
patient
comparison we should not
population?
do.
What was the difference between these two trials? What were the differences?
Ma'am, please, ma'am, again.
Differences between solo 1 and Paula 1?
Ma'am,
In patient population, you think we can compare these two trials?
No, ma'am, we should not
can't
do.
compare. Can't compare.
We cannot compare. Cross trial comparison should not be done. There, they have taken only germline or somatic BRCA mutated in the solo 1 trial, the patient that they used. Only then they are eligible for olaparib in solo 1. But that is not the situation in Paula.
Paula trial
So
was
what
done
was
for.
the situation in Paula trial? What
Or,
was the difference?
Yes.
It was basically an HRD positive group also. It included Paula.
Right.
HRD positive, irrespective of BRCA
Stage
mutation.
3, stage 4 advanced, optimally debulked with complete response, partial response, where they have used
I think that's move to specimen. No?
Okay. Next one. I think don't have time. Go to specimens now. We can't cover now. No time is there. Next one. What is this specimen?
This is a Kotopan specimen of uterus, showing uterus and the cervix with the endometrial cavity and the endocervical canal visible, where you can see a necrotic growth on the body of the uterus more towards the lower uterine segment. who is invading the myometrium. So probably this is a case of carcinoma endometrium.
Okay, carcinoma endometrium, invading the myometrium.
Sir.
Okay, next one. What is this?
So, are you sure that's a case of CA endometrium?
No,
The
ma'am.
previous one.
No, ma'am.
Could you see tubes and ovaries?
No, ma'am.
What else it could be then, if not endometrium?
Come back to the previous slide. Just go back to the previous slide. Yeah.
Are you seeing tubes and ovaries?
Ma'am, I don't know. Like here, though it is.
So, what would be the thing here? Why? Suppose if I say tubes and ovaries were not removed.
It could be adenomyosis. I don't know.
Just think of other conditions where you will remove only the uterus and not the tubes, and there's a necrotic red color vascular type ka growth is present in the cavity.
It could be GT and I don't know. Then like our PSTT and ETT kind of thing. Maybe. I'm not sure, ma'am. Just I'm guessing.
Okay. In endometrium, are there cases where you may preserve ovaries?
Grade 1 endometrioid
Yes.
All?
No, ma'am.
If the patient is willing for follow-up and if the patient is um, planning to preserve fertility, then we can preserve only in grade 1 endometrioid carcinoma.
No. Regardless of
You
patient's
can
age, desirous for fertility, you preserve ovaries?
Yes, sir.
Is
No,
it?
ma'am.
If she is willing for fertility preservation and if she is willing for regular follow-up.
Okay. So, which cases you will not preserve ovaries in endometrial cancer despite like patient desirous of fertility apart from advanced disease? Any other situation where you may not like to preserve ovaries?
Particularly if they have genetic
Ovaries.
syndromes, Lynch syndrome or Gynec syndrome. If it is
Yeah,
a
not.
syndrome,
Yes.
All
ma'am,
the
sorry, ma'am.
cases we have to remove the ovaries. Only in the condition where you are planning for fertility preservation, that is grade 1 endometrioid. All other cases we have to remove the ovaries.
Okay. So, in Lynch, which has the least risk of ovarian malignancy amongst four?
PMS2. PMS2.
PMS2. Loss of PMS2. Hello.
Hello, am I audible?
Yeah, okay.
Ma'am, you are muted, I think.
Mita is muted, yeah.
Yeah. No, Dr. Bafna, you have a question? Otherwise, I think we are just coming.
You asked something about Lynch syndrome, no?
Yeah, no, that's okay. He said PMS2, that's the right answer. That the least risk of ovarian malignancy is in PMS2.
Okay. Okay, then go to the next slide now. What is this case? What do you think it is?
This is an intra picture where a longitudinal incision showing uterus and both the ovaries, where both the ovarian masses are irregular and they are multi-bossulated and surface is looking smooth here. So it is a bilateral ovarian tumor, sir. Mostly it is a metastatic secondary disease in the ovary.
Kuchenberg tumor. By looking at this, you can tell it's a Kuchenberg tumor. Kuchenberg tumor got classical appearance. Can you describe Kuchenberg tumor?
Yes, sir. They are
Mostly bilateral.
Smooth surface
Bilateral.
of
Then
8
what
to
else?
10 centimeter. Surface is smooth. They are not very
oscillated.
Yes, sir.
Then
And they are not very big. They are moderate of 8 to 10 centimeter in size.
moderate size, bossulated surface, waxy appearance. They classically waxy appearance.
Sir.
And usually mobile. Usually quite mobile. They are really mobile. Here, I think it fits into the criteria of Kuchenberg tumor.
Sir.
Okay. So what could be the primary site here?
Mostly, if I Kuchenberg, stomach is the most common site, sir, and breast also.
What is the common thing you said?
Stomach, sir. Stomach
cancer.
Stomach and which other cancer? In females?
Breast cancer can be.
Okay. And
And
you're not seen from colorectal?
Colon, from
yes,
colon,
ma'am. Yes, ma'am.
colon also.
Now, sir
Colon.
asked about Krukenberg specifically, so I
Yeah, I'm
told
talking
it's.
about Krukenberg's only. I mean,
But
what is the difference between other meds and Krukenberg? How all ovarian meds are Krukenberg?
no, ma'am.
So what is the
If it is
characteristic of
if it is a signet and that in my histopathology that we are seeing, and the metastasis is mostly from stomach, they call it as classical Krukenberg. But yes, as you told me, signet ring can come in the GI, in the colorectum, in the intestine, and it can have also uh, bilateral ovarian masses resembling Krukenberg, and we can tell them Krukenberg.
go to the next, or do we? Yeah, I think 5. Seema, can we take 2-3 minutes more?
Yes, ma'am.
So some of these Krukenberg may present with bleeding per vaginum. Have you seen any time patient with Krukenberg coming with bleeding?
No, no. I
No.
have no.
Yeah.
No.
So what is the cause for bleeding in Krukenberg?
It is due to, I'm not sure, maybe the ovarian stimulation, more hormones and causing endometrial
Yeah, so there can be stromal stimulation. And which other tumors of ovary can present with bleeding?
all are sex codes, all hormone secreting tumors,
Estrogen
particularly
secreting
sex code stromal tumors.
granular cell tumor.
Okay. And androgen secreting tumors?
No.
Hmm.
Have you seen any time patient
Well,
coming with virilization? With red
yes.
blood cell mass?
I have
Androgen
seen,
secreting tumor
yes,
can present with virilization and mass, but I have not seen.
Okay. Can we go to the next slide?
Thing here. What is it?
this second one intra picture showing a huge ovarian mass with I can see
Solid
the
tumor.
IP and the yes, yes, sir. It's a solid cystic, appearing solid cystic tumor to me. It's a huge mass, so probably this is a mucinous region. Yes.
Vision,
Can be stromal tumor also. It can be stromal tumor also. Fibrosarcoma or something.
What are the solid, basically solid tumor? What are the solid ovarian tumors you come across? Solid.
Sir, Brenner tumor,
Brenner's tumor.
the germ cell tumors, sir, like our
Which germ cell is solid?
dysgerminoma is solid, man.
Okay. Which other tumors are solid? Very, very solid actually. The classical solid.
Fibromas,
Fibroma, thecoma.
fibroma and thecoma very rock solid. They are very solid, man. And
Stromal tumors also.
stromal tumors are solid. Six.
Sex cord stromal tumors are solid. Granular
cell tumor
could have cystic degeneration. Basically solid tumor, but they can have cystic degeneration also.
Yes, yes, sir.
Okay. But this case particularly was supposed to be, it turned out to be Kuchenbach tumor. Okay. Quite big one. Unilateral solid tumor turned out to be Kuchenbach tumor. So Kuchenbach tumors are classically bilateral. But sometimes you can have unilateral tumors also. This thing should be kept in mind.
Sir.
Okay. So I put this.
Next slide. I think we can go to the next slide.
What is this? Dr. Amita has given these pictures. What are these pictures?
This is adnexa. So anyway, we can go to the next slide. Okay.
This is also bilateral tumor. Is it Kuchenbach tumor?
No, sir. This is a lot of capillary growth. Both the ovaries.
You know, what is your clinical impression looking at these masses?
It could be mostly borderline or low grade serous.
Yeah, quite classical. Of course, you need to have histopathology, but classical of low grade or borderline. How if she's a young girl, unmarried, what will you do? What will be the surgery? Extent of surgery?
Ma'am, if it is borderline all stages, I can go for fertility sparing surgery.
think
But
in this
here,
case you will be
ma'am,
able to
We can
spare.
only you can
uterus.
preserve the uterus here.
We have to
Both the
exercise
ovaries and
both
lobes
ovaries.
extensively involved.
Uterus can be.
Only you can preserve uterus here.
Right.
Can you preserve the ovary also? You can see something, some ovaries there.
Yes, sir. If
Is it
if
possible to
one
preserve
side,
the ovaries?
sir, yes, sir. The severely affected side, we can do salpingo-oophorectomy. The
What
less
will be
affected side, if some healthy ovarian tissue is there, we can go for cystectomy or tumorectomy and leaving behind healthy part of the ovary.
Okay,
But
now
yes,
tell me
of
now,
course,
is it possible to do oocyte retrieval in this kind of cases with bilateral ovarian tumor, borderline ovarian tumor? Oocyte.
difficult, sir, from assessing the healthy part of the ovarian with such big masses. The assess will be, I think, will be difficult when they will retrieve the oocytes.
No, that is possible. I think a few of my cases, bilateral ovarian tumor, borderline ovarian tumor, we are able to see the ovarian follicles, and we were able to retrieve the eggs vaginally. Normally, it is done vaginally by transvaginal sonography. So
But
even though you have,
classically, I think, I mean, most of us, one, stimulation will be little, challenging in these cases, contraindicated, because these are
Because
estrogen dependent
ER
tumors.
positive, yes, ma'am.
And of course, you need to have a very good sonologist. Maybe
no,
doctors.
but it is possible because
Okay.
nowadays you have a short stimulation protocol.
Okay.
You can stimulate in a short time, 10 days time, 15 days time, you can finish a retrieval of ovaries. It is possible, and that patient, my patient has conceived also after that.
Oh, great.
It's possible. And the problem is that sometimes you can have contamination with malignant cells. That is the fear. When you are retrieving the
Yeah, that's a real
right,
fear, actually, contamination.
contamination fear is always there. Okay, next one.
Next slide.
What is this given by Dr. Amita? This one?
Sir, this is post radical vulvectomy. This is an advancement flap from the gracilis medial aspect of the thigh for reconstructing the vulva. And in the second picture, you can see post reconstruction. This is VY flap, where we have taken a VI and sutured it as Y.
Okay. With any comments? This is your picture. Any comments, Amita?
No, so I want to ask,
Hello.
what all flaps we use for vulvar reconstruction?
Use lotus flap or gracilis flap, and BY flap. These are
Flaps can be only that split thickness flaps, or it could be a myocutaneous flap. They're broadly, or we can just put a skin graft. But mostly
graft, I don't know how often you all use graft. We by and large don't use graft after
yes,
vulvectomy.
Yes, ma'am. No, these are what is
Mostly local advancement flaps.
Local
advancement.
lotus, yes, yes. Rhomboid flap or lotus flap or VY flap. These are most commonly used for vulval surgeries.
Okay.
Yeah, nowadays, we use neoadjuvant chemotherapy, or many times we use chemoradiation for advanced vulva. So the need for flap has come down now. Like in earlier days. So neoadjuvant chemotherapy, even though not well described, there are not many papers, many publications.
Yeah, but we would prefer in young patients, especially sexually active, because many times post without reconstruction there can be severe vaginal stenosis, introitus stenosis.
Yeah.
Yeah. Next, do we have more slides?
Next one. Lymphedema.
This is lymphedema.
So how would you prevent it and treat it?
Prevention of lymphedema, while when we are doing particularly immunohumoral surgeries, we can go for lymphovascular anastomosis. We can spare the saphenous vein when we are doing lymphodissection. We can do even at least wherever it is possible to do SLN in CA vulva, not to go for complete lymphadenectomy. And we should use stockings post surgery and limb elevation and physiotherapy the massage that they give post surgery.
So this, this need not necessarily be always after groin. Even after pelvic
Yes, ma'am.
lymphadenectomy,
We
you
can
can. So what can you do for if you are doing pelvic lymphadenectomy?
multiple ligate clips.
Intraoperatively, you can clip the proximal
Clip,
limit of our lymphatic vessels, which will prevent lymphocyst or lymphoria. So that can be done, ma'am. The
Yeah,
ends
and
of
one thing what we have start doing in our practice is we don't remove distal most external iliac cloacae kind of lymph node,
yes,
and
ma'am.
that has reduced lymphedema rate in our patients.
Yes, ma'am. My
Of
madam
course,
also
you
does the same.
mentioned about sentinel lymph node, which can be practiced for endometrium, cervix, as well as vulvar cancer in suitable cases.
Yes, ma'am. Yes, ma'am.
Yeah, I think after the concept of sentinel node biopsy has come, very rarely we find sentinel node at the distal most area, where external
Yeah.
iliac artery is becoming femoral artery. That is the node I think we used to remove earlier days. I think that node can be preserved, I think.
Yeah, and we have now, I don't know, you also must not be removing that node.
Yeah. Unless you have a lymphatic metastasis.
Yeah, which is very
you
rare.
have, yeah. Established lymphedema, very, very difficult to treat. Okay. This kind of
Yes.
edema, can you treat with lymphovascular anastomosis?
Sir, it depends on the duration post surgery when the patient is presenting. The more
massive lymphedema,
no, sir, no, sir.
possible to prevent?
No, sir. Once lymph has come to the interstitial space and it has established fibrosis, it is very difficult to reverse it back.
Very difficult because fibrosis sets in. Very difficult to reverse it back even after doing lymphovenous anastomosis. Sometimes you can do lymph node transfer. They do lymph node transfer
Yes.
and anastomosis. They do it.
Yes.
But I personally have not seen any success rate with established lymphedema because fibrosis sets in. You can prevent progression, but you cannot reverse it.
Yes, sir.
Okay, next one.
Quickly, I think it's 8:42. Yeah, in 3 minutes we should close. What is this?
So again, picture given by Dr. Amita. What is this classical picture? I have not seen. Very rarely I see this kind of picture.
We see it quite often. So we discussed actually what are we seeing? If you can describe.
This is some in the back of the patient showing some ecchymotic or some hyperpigmented patches all throughout the back.
This is quite classical of bleomycin
Induced.
use. The patient would scratch and this kind of thing. So we do see it quite often.
It's called as flagellated pigmentation induced by bleomycin. But personally, Amita has seen, I have not come across, I think maybe I have not noticed. Bleomycin we give, but I have not noticed it. Maybe I have not seen them. Okay. So this is classical of bleomycin induced flagellated pigmentation. As if somebody has flagellated you, somebody has whipped you. So this is classical of bleomycin toxicity. Next one. This one.
This picture is little challenging to interpret.
Post conization of cervix.
Very good.
Conization.
Conization or post leap actually.
Okay, maybe.
What are the complications of leap procedure?
Intra there will be bleeding and inadvertent injury to the vaginal walls, and post surgery.
So how do you prevent these two, injury and bleeding?
Ma'am, first thing is we can pre-operatively we can take hemostatic sutures at 3 o'clock and 9 o'clock position. And while putting a speculum, we can use instead of metallic, we can go for insulated speculums.
Yeah,
and
I think you should use insulated only, not can use. You should use insulated speculum.
Yes, ma'am. Yes,
there
ma'am.
are speculum especially designed with smoke evacuator, so vision is clear and there is no risk of. And you also have insulated lateral vaginal wall retractors, right?
Yes, ma'am.
For leap, generally we don't take these hemostatic, more so when we do conization. What cautery setting you use?
We use 40-60, ma'am.
40 calculate.
40 cutting and 60 coagulating.
So for main procedure, we prefer pure cut so that there is no thermal
Yes,
artifact.
yes.
And then, of course, you have ballpoint to cauterize.
Yes.
I think Dr. Bafna.
Yeah. Basically, you have to use blend current, blend of cutting and coagulation. Pure cut you are going to use, then you're going to cause a lot of bleeding. So better to use a blend current. And different machines have different settings. Blend 1, blend 2, different blends you have. So you have
Yes,
to be familiar with the machine, and accordingly you have to choose the blend current. Okay, next one I think, and we'll end the session I think at 8:45.
So this is an intra picture against our
Left side and the right side of the picture, big vein is there.
sir. That longitudinal it is the IVC on the right side. Just below our on the side I can see the renal also going, and on the left side this is the I think gonadal vessel draining to the left gonadal. Yes,
Left
left
gonadal.
Is it gonadal vein or is it inframesenteric vein?
Inframesenteric will come little down, sir. I can see the renal and I can see it is draining to the renal. Inframesenteric
Entering the renal vein, isn't it?
Yes, sir.
Yes.
So it is a gonadal vein, not inframesenteric vein.
So what are indications for this procedure in modern day gynec oncology?
Modern day
Staging of early ovarian cancer.
Early stage.
Staging of early ovarian cancer.
Okay.
And
if these nodes are positive, what will be the stage? Otherwise, ovarian confined disease.
Stage 3A.
Okay.
Depending
so
on
one is ovarian cancer. Then which other cancer?
In advanced ovarian cancer or advanced endometrial cancer, if there is enlarged or bulky nodes, then those can be removed. But only the enlarged and bulky need to be removed in advanced and ovarian or endometrial cancer.
Right. Rarely, maybe in germ cell tumors, we do this procedure post chemotherapy, especially dysgerminoma, if there is residual disease in retroperitoneal lymph nodes.
Basically, systematic lymphadenectomy, thorough lymph node resection is nowadays not recommended in many of the cancers, especially in ovarian cancer. After the Lions trial, you don't remove it. Don't do a thorough dissection. Remove only the bulky nodes. And concept of systematic lymphadenectomy, even in endometrial cancer also, is coming down. Even in high-risk endometrial cancer also, if the nodes are looking normal and sentinel node is removed, then there may not be need for systematic lymphadenectomy, even though we don't have randomized control trials. But that is the concept which is emerging. You don't have to do a systematic lymphadenectomy of normal-looking nodes or normal imaging. So, because lymphadenectomy is not supposed to be therapeutic unless they are bulky or suspicious. I think that is a concept which is emerging now.
Should we close now, Seema?
I think the time is up. I think we should be able to close now.
Time is up.